Good afternoon, everybody. Kalispera σε όλους. Today, I have the pleasure and honor to introduce you Dr. Vgontzas, who is going to give the talk in the lectures. Dr. Vgontzas has been my mentor, my collaborator, and a very dear friend for over 20 years. He is a professor of psychiatry. He's a psychiatrist and professor of psychiatry in the Sleep Research and Treatment Center in Penn State College of Medicine in Hershey, Pennsylvania. And he is also a professor of psychiatry in the School of Medicine in the University of Crete in Greece. Dr. Vgontzas is board certified in sleep medicine, and his work has been pioneer in the sleep field. He has a very significant contribution, focusing mostly in neuroendocrinology of sleep and insomnia. However, during the last years, his contribution in the field of aging has also been significant. And in 2013, he was the primary investigator in a project that we ran in the University of Crete, in the School of Medicine there, on frequency and risk factors associated with cognitive decline that led to the establishment of the Cretan aging cohort. Currently, he is a co-investigator in the follow-up project of the Cretan aging cohort on sleep apnea and poor sleep as risk factors for decreased cognitive performance in patients with a mild cognitive impairment. So I'm not going to say any more. The title of today's presentation is Insomnia with Short Sleep Duration and Cortisol are Risk Factors for Cognitive Impairment. And I give him the floor for a very promising presentation. Dr. Vgontzas.
Thank you very much, Maria. Thank you for your introduction. I'm going to try to, oh no, I did something here wrong. Oh, here it is. Oh, what happened? Okay. I guess everything is okay. I'm asking the technical person. Everything's okay? Okay.
Looks fine.
Okay, all right, all right. So today I'm going to, my end goal, my rather objective is to tell you that in order to have precision medicine, it's not necessarily that we have that we include genes and genetic information. Other simpler measures can help us to end up in what we call individualized and precision medicine. I'll take you also in a trip of about 40 or more years, because I would like to take you all the way from the early studies in insomnia to today. And in some of them, I'll do just a brief introduction. I'll show you a slide with a paper that if you're interested, you can go and look at more detail. Now, this is my first slide and shows the categorization, the classification of insomnia based on different classification systems. DSM-3R is, the Diagnostic Statistical Manual of the American Psychiatric Association. ICSD is the International Classification of Sleep Societies, including the American, European, Japanese, and so forth. What I would like you to focus and highlight is that if you go in the earlier definitions, in the earlier other classifications, you see a lot of subgrouping, a lot of different types of disorders within insomnia. If you go like to the ICSD, it's more than 18, 20. And as you see, as we move from these earlier years to the most recent ones, 2013, 2014, we end up with only one diagnosis. So from the many subgroups, we ended up only with one. Why is that? I'll show you in a second, but bottom line, the previous classifications did not appear to be valid and reliable. So now we have one diagnosis that everyone can agree that this person has insomnia. But you know what is the problem with one diagnosis? Everyone agrees, but then there's no any specific guidelines about how to treat someone. So everyone treats according to their training and personal choice. If I'm a pharmacologist, I use drugs. If I'm a psychoanalyst, I use analytic approach. If I'm a CBT guy, I use a CBT. Here is the picture of Anthony Kales. He's one of the pioneers in the sleep field. Actually, he's of Greek origin. He was born in Detroit by Greek immigrants from northern Epirus, southern Albania. But he was born and raised in Detroit. He studied there. He became soon a professor at UCLA. Then in 1971, he moved to Hershey, Pennsylvania. And this is where I'm now located. And he was one of the pioneers. And I have to say, just for his historical justice, he was the first one to establish a sleep disorders medicine clinic at UCLA in 1963. Now, Tony Kales, being a psychiatrist and being a psychoanalyst, approached insomnia from a psychiatric standpoint, that insomnia is primarily related to depression, primarily related to anxiety. He published a lot of papers, 1976, 74, 75, and further on. Another group that was also in West United States, in the West Coast, at Stanford University, and here is the famous Guilleminot disease, now Guilleminot and demand and so forth. They say, no, psychiatric factors are not important. There are other factors, physiological, sleep pathology, such as sleep apnea, nocturnal clones, and so forth. And they published, their first classification in 1979 that included polysomnographic criteria. Like for every subgroup of insomnia, they had polysomnographic criteria, like more than 30 minutes to fall asleep, more than 7 hours, and so forth and so on. So this is when I joined this group. I joined this group in 1985. I started working with sleep in 1988 and 89 after the end of my residency in psychiatry. And this was back then a big confrontation, and I will say a fight. And one of the things I was assigned to do is to assess the clinical utility of sleep lab criteria proposed by SDA. And we found that using MMPI, which is a psychometric test, it gives you better validity and better clinical utility than using the polysomnographic criteria. But I have to say, I felt there was a lot of resistant publications of these papers. There were a couple of those back in the early 1990s, and ended up in International Journal of Neuroscience with an impact factor of about 1 or something like that. Many years later, Jack Endiger, whom I did not know at that time, although now we're close collaborators, and he was the chair of the committee for the insomnia diagnosis and subdiagnosis. They published a multi-site trial, and they found that the reliability and validity of the DSM-4TR, nice institute insomnia diagnosis, excuse me for my cough, but I just got a cold, they were not reliable and they were not valid. So in 2002, the American Academy of Sleep Medicine, they said that there is no validity to use a subgroup and a subtyping in insomnia, and also don't use the sleep lab, use it only to rule out sleep apnea and nocturnal malclonus or periodically movement. So at that time, given all these negative things, yes, we have shown that sleep lab was not very useful, but then what do we do? So when you're stuck, you go back to the origins, and the origins is trying to find out what is the pathophysiology of that disorder. One of the predominant theories was the theory of hyperarousal, that poor sleepers, insomniacs, they are psychologically and physiologically hyper-aroused. This is from the thesis of a person I have never met, Lawrence Monroe. I don't know if he's still alive, from 1967, but he was a pioneer, and always I feel the need to always give credit to the pioneers. Many studies came afterwards, including Kales, including Bonnet, including many other people, that they found physiological activation, they studied heart rate variability, they studied metabolism, they studied MSLT. MSLT is the sleep test, multiple sleep latency test that assesses how fast you can fall asleep during the day. So if you fall asleep fast, you are sleepy, like in narcolepsy hypersomnia. Insomniacs, although they say they don't sleep well, but during the day, and they say I'm fatigued and I'm tired, but during the day, if you have them go through this test, it takes them a long time to fall asleep. So everyone ends up that there is a physiological hyperarousal and cognitive hyperarousal through rumination, and also Tony Kales said through internalization of emotions. Okay, at that time, at NIH, it was George P. Crusos, a common friend, brought me in contact with George, who is an international known researcher on stress. And I started working with him, tried to understand better the pathophysiology, both sleep apnea and insomnia. It is true that I have done an equal number of studies, both in sleep apnea and insomnia. But today I'm going to focus only on those on insomnia. So with George, we published the first paper in 1998, and where it was just a simple study, 24-hour study, rather 4 nights in the sleep lab, 24-hour urine, where we measured urinary free cortisol, norepinephrine, epinephrine, the metabolites. And what we found at that time, that there was a very strong correlation, positive correlation between indices, polysomnographic indices of sleep disturbance, for example, total sleep time, wake time after sleep onset, and the levels of cortisol. So this was something that we did not expect. And then we went with a 24-hour study where we included controls. It was sampling of blood every half an hour, 48 samples, both in controls and in insomniacs. And there we found that insomniacs had higher levels of ACTH and cortisol in their 24-hour pattern compared to controls. And then what we found is that those insomniacs that were sleeping less than 6 hours, there were those that had high cortisol. The other guys that complained of insomnia that were sleeping better in the sleep lab, objectively, they did not have high cortisol. And we continued, of course, with more studies on inflammation, and we saw that there was a shift of interleukin-6 and human nephrosis factor from nighttime to daytime. One thing is here, I'm showing at least 4 studies that they have 24-hour data, multiple 24-hour data from mild sleep, for total sleep deprivation, from mild sleep deprivation, from total sleep deprivation followed by daytime napping, from mild sleep deprivation followed by recovery of sleep. This was 13, 14-day studies. And we saw that under non-stressful conditions in normal subjects, sleep deprivation was not associated with cortisol elevation. Therefore, we concluded that sleep loss and insomnia are 2 different things. So we said that chronic insomnia is a disorder of 24-hour hyperarousal, both physiological and cognitive, and not just sleep deprivation. Okay, then we wanted to further validate our finding that insomniacs with short sleep duration had higher cortisol. Given that higher cortisol, if it's in a chronic condition associated with several health conditions, because we didn't know that insomnia was associated with depression and anxiety. No one is now denying that. But one of the issues was, is insomnia associated with any medical, with any health issues? I'll just give you a short glance at the literature in the 2000s, and people said, major investigative groups said, no association with cardiometabolic morbidity, no association with mortality. In fact, Kripke from the West Coast said, if you have insomnia, you live longer. And so, if you have a condition and makes you live longer, why to treat it? It's just a simple question. And then we said, okay, let's try now the new approach. Let's divide insomnia based on these characteristics. Short sleep duration, higher cortisol, insomnia, normal sleep duration, no higher cortisol. Is there a difference in terms of several outcomes, like hypertension, diabetes, and the like? We use the Penn State cohort. Shortly, what is a Penn State cohort? Established by my colleague, professor, and friend, Edward Bixler, in 1990. 16,000 they were screened on the telephone. 1,741 they were brought in the sleep lab, 1 hour polysomnography, complete history, and so forth. And this is the first study that we demonstrated that insomnia with short sleep duration below 6 hours is associated with 3.5 odds ratio compared to normal sleepers. And if you move the cutoff to a shorter time, less than 5 hours, this becomes 5 more times. So we said, well, that's the first step. It was published in 2009, and it was associated with a very nice editorial from Professor Bonnet from the University of Ohio, where he said insomnia is not just a merely behavioral or mood problem, but is a real medical problem, and that has equal importance to the other one, sleep apnea. As you know, most specialties, including cardiologists, pulmonologists, and so forth, they have in their books, in their classifications, sleep apnea as being a major risk factor for diabetes, for heart problems, and so forth, but not insomnia. Then we went with diabetes, we found similar findings. And then we continued and we saw persistent insomnia because, as you know, insomnia fluctuates. Many people don't have it all the time. So we focused on the more severe ones, which is the persistent insomnia. And we found 2 were the factors that can predict the persistent insomnia. The one was objective short sleep duration, and the other one was depression. And then, because many insomniacs, they say, I don't sleep well, I sleep only for 2 hours and so forth. Sometimes we play some games with them. Well, if you sleep 2 hours, you're going to die. No, doctor. So we bring them to the sleep lab and they sleep for 7 hours. And they said, oh, your machine is wrong. Your sleep machine is problematic. I slept only 2 hours. And this is the so-called sleep misperception, okay? Mismatch between how much they sleep and how many hours they feel they sleep. And we found that this problem is primarily those that sleep better and not in those, let's call them the real insomniacs, don't want to use that term, but the insomniacs with short sleep duration. And then because obviously there is the question of chicken and egg, which came first. It was the insomnia that caused hypertension or hypertension that caused insomnia. And in this study in 2012, we demonstrated clearly in the Journal of Hypertension that it is insomnia with observed short sleep duration that leads to incident hypertension. And now data from our colleagues, former students and colleagues from China, they saw the same thing, that these insomniacs that on MSLT, they were showing signs of hyperarousal, like it took them longer than normal individuals to fall asleep. Also, they were associated with hypertension, with the risk of hypertension. And at that time, Jack Edinger, who is along with Charles Morin, these 2 psychologists that I introduced, cognitive behavioral therapy insomnia, which is now the current predominant prevalent behavioral method for insomnia. Actually, according to the American College of Physicians, the first-line treatment. At this moment, the United States, and I think all over the world, cognitive behavioral therapy is first-line treatment, no medication. So he said, I'm going to his joke, he likes to joke, and he said, well, I wanted to show that Alex was wrong, but then he found out in his own data that objective short sleep duration, not subjective, please make sure you notice this distinction, objective but not subjective short sleep duration is associated with increased risk for hypertension in individuals with insomnia. And then other groups start working on that from neurobiology. This is from China, objective sleep duration associated with cognitive deficits in primary insomnia. The BDNF may play a role. That insomnia with short sleep duration is associated with short telomere length that has to do, as you know, with aging and medical problems. This study came from Brazil. Then from our own lab in adolescents now, Dr. Fernandez Mendoza in 2016 published a study where young insomniacs that had higher levels of beta and low beta and high beta frequency during their non-REM sleep. And he found later on, again in adolescents, that those that they were sleeping less than 7 hours, and 7 hours because adolescents sleep more, young people sleep more than older. The 6-hour cutoff is based on a large random general population sample with aging ranging from 20 to 90, and he found associated with CRP with inflammation. Also in a recent study that we did with George Crusos, and this is using CRH, that is to stimulate the access at the ACTH level and then to cortisol. It's a method, to explore further the mechanism of the activation, and we found that the response of chronic insomnia, in men with chronic insomnia, to CRH is different than those that depression, because all this has been felt since insomnia is depression, therefore insomnia equals to depression. Biologically, pathophysiologically, that's not the picture we have. More important, from all that have been published, I want to show you a study that was published just this year at PNS. This is a publication of the American Academy of Science, and they analyzed data from the UK Biobank of 103,000 persons that they have actigraphy. Actigraphy is not as accurate as polysomnography, but is a good substitute. And they used it for 1 week, and they were looking for genetic phenotypes. And what they found is that the genes were associated with 3 groups: the long sleep duration, normal sleep duration, and short sleep duration. And I'm going to read the one that I have highlighted in yellow. Those differences demonstrate that it is important to describe subjects with insomnia in more detail based on how much they sleep. In other words, they accept our concept, they accept our model, that if we are going to understand genetically insomnia, it makes sense, besides the complaint of insomnia, because now insomnia is based on a complaint, we have to find an objective way of measuring total sleep time. And because, some of the criticism was that most of the studies have come out of the Penn State group. This is a chapter that we authored along with colleagues from the University of Pittsburgh. And this is from the Principles and Practice of Sleep Medicine. It just came out. And in this chapter, we include from different groups 12 studies on hypertension, 7 studies on metabolic dysfunction, 10 studies on cardiovascular disease, and 10 studies on brain health, that they are demonstrating the validity of the phenotype of short sleep duration. Now, in this figure here, I will illustrate the differences and some overlap between the two phenotypes. So, insomnia with short sleep duration, to your right, it's biological vulnerability, genetic predisposition, high sensitivity to activation of arousal and stress systems, physiological hyperarousal, impaired neurocognitive function. I'll show you some data in a bit. More likely to persist, increased risk of cardiometabolic morbidity and mortality. In contrast, the insomnia with normal sleep duration that don't have any of these, they have the sleep misperception, they have the anxious ruminative profile, more likely to remit, no significant risk of cardiometabolic morbidity and mortality. There is some overlap, such as psychological vulnerability, cognitive and emotional and cortical arousal, and increased risk of psychiatric disorders. Now, I want to focus, since this is the focus of this group, of this phenotype with cognitive deficits and cognitive impairment. So in 2010, while we're looking, to see how is this phenotype related to several domains. I told you about hypertension, diabetes, persistence, mortality, and so forth. We decided to look with a psychologist from Spain, who is now a colleague of ours at the Penn State, Fernandez Mendoza, and he did an analysis and he found that insomnia with objective social liberation is associated in deficits in set switch and attentional abilities, a key component of the executive control of attention. In a newer study that he did, he demonstrated that insomnia with objective social liberation, but not the insomnia of normal sleep duration, is associated with cognitive impairment, particularly that cognitive impairment associated with known cardiometabolic risk factors, and they call it, vascular cognitive impairment, and this includes hypertension, diabetes, heart disease, and stroke. So the conclusion of the study was, the recent one, and got quite a lot of publicity, shows that insomnia with objective sleep duration associated with prevalent cognitive impairment, particularly as it relates to vascular and metabolic contributors to brain health. Now I'm going to present in a little bit more detail two studies from the Thalis cohort, the Cretan cohort, the Cretan aging cohort that Dr. Mpasta talked to you about. This was a cohort established since 2013, and now there is a follow-up study that the PI is Maria Basta. So in this study with two good colleagues, Aki Simos, he is a professor of neuropsychology in the University of Crete, along with his student Antipa, they decided to look at the basal cortisol levels because cortisol, AM cortisol, and the morning cortisol, how it is associated with memory and executive function. And in that study, we explored whether the association of elevated cortisol levels on episodic memory could be partly attributed to cortisol effects on executive functions. Here is some more details about the subjects that participated. You can see on the top, from the 3,200, how we ended up in the 236 subjects that participated in that study that was part of the stage 2 of that project, and participated 84 that they were cognitive non-impaired, 99 with mild cognitive impairment, and I cannot see now the number, and a group with dementia. You can see the measures they used, the executive control index, the immediate memory index, and the delayed memory index. And, and based on this data, they did the mediation analysis, and they found that the association of cortisol with delayed memory is through executive function and through immediate memory. And based, because I'm not a neuropsychologist, based on this interpretation, that's significant because now there are some trials where they are trying to interfere or training or improving the executive function so they avoid the effects on delayed memory and further cognitive decline. So in this study, the conclusion was that the conclusion was that the relation between basal cortisol levels and delayed memory performance in elderly is mediated by the performance in tasks of executive functions and immediate memory. And we found that primarily in patients with mild cognitive impaired. Now, the next study that was initiated by us, the sleep people, we wanted to see whether in patients with MCI with mild cognitive impairment, two questions. Was cortisol elevated in mild cognitive impairment compared to those without mild cognitive impairment, the normal controls? Second, did the phenotype, the insomnia short sleep phenotype, was it playing a role? And again, this is like the flow of the study. In this study, we have 208 participants with 24-hour actigraphy for 3 days and morning serum cortisol measures. 124 of them, they have MCI, 84 of them, they were normal controls. As you can see here, you can see the demographic and clinical and sleep characteristics of these two groups. And as you can see, the cortisol, the morning cortisol, was significantly higher in the patients with MCI compared to those with normal controls. I have to say that usually, if you measure cortisol in the morning, there is a chance not to find significant effects because the system is very active, and sometimes, the possible differences are hidden. The best way to measure cortisol, if you want to find differences, is when the axis is quiescent and quiet after 6 p.m. And then the next question was, okay, cortisol is elevated in patients with MCI compared to normal controls, but what's happening as far as the role of this phenotype of insomnia with short sleep duration? And here is the figure from that paper, and you can see on my left, as I see it here, there is the non-insomnia group. Next to it, the SSD means short sleep duration, which without insomnia. They have short sleep duration, but without insomnia. Next group to those is insomnia, but with normal sleep duration. And to the far right is the group with insomnia and short sleep duration. And as you can see, there is a dose effect, and the group with the highest cortisol levels is the insomnia group with short sleep duration. Yes, there is also non-significant but close significant elevation also in short sleepers. So we ended up that the increased cortisol levels that we see in patients with MCI are primarily driven by this phenotype. By the way, in all these stats, of course, we have control for age, sex, gender, depression, psychotropic medication, and everything else that is relevant. And so we concluded that both short sleep phenotypes, the insomnia and the non-insomnia, are associated with increased cortisol levels in elderly with MCI, and that improving the duration of sleep and decreasing cortisol levels may prevent further cognitive decline. Now, I'm going now to the treatment implications, because why we diagnose people? The one is for clinicians to communicate, to have clear communications. Also for the researchers to have clear communications. But more important is to come with specific diagnosis. This is what we call now precision medicine. And we felt, based on preliminary data, I'm going to show you, that the phenotype that we call short sleep duration may respond better to biological treatments, such as antidepressants, while the second phenotype, the normal sleep duration insomnia, may respond better to psychological treatments. And here is our good friend now, Genedis, who has said that he likes to crack the joke that he always wanted to prove Alex wrong. And what he found is, as I said, Genedis and Charles Morin are the founders of cognitive behavioral therapy in insomnia, which is first-line treatment. And what he found and published in 2017 is that insomnia patients with objective sleep duration have a blunted response to cognitive behavioral therapy for insomnia. Just to give you a little background, about 50% of the people respond to CBTI. Not everyone responds to CBTI, although it's first-line treatment, even according to the American College of Physicians. And what he found is that 80% of normal sleep duration responded, this was a retrospective analysis, of course, responded to cognitive behavioral therapy, and only 20% of those with the phenotypes of sleep duration respond to CBT. So we said, here we are. This is the first evidence that this phenotyping has significant treatment implications. Well, there were a couple of studies that they were negative, so we did a meta-analysis. My colleague Fernandez Mendoza made the meta-analysis, all of the published studies on whether the insomnia short sleep phenotype moderates the effect of cognitive behavioral therapy, and I'll read you the conclusion that this data suggests that the insomnia short sleep phenotype is 24% less likely to remit after CBTI than the normal sleep insomnia phenotype. In the meantime, we're working on a pilot study where we compare trazodone. Trazodone is the most prescribed sleeping agent in the United States, although it's not approved by FDA, although it's an orphan drug, no industry supported, but based that many of the benzodiazepines and the benzodiazepine receptor agonists, they have problems with tolerance and the dependence and their controlled substance and all that. Many physicians, many of them, of the general practitioners, they use this medication, which ordinarily was marketed for depression, but then physicians discovered on their own that small dosages has a good hypnotic effect. And as I said, at this point, is the most prescribed medication in the United States. It's also very cheap because there is no patent anymore. It's been in the market for more than 40 years. And we decided in a pilot study to compare trazodone versus cognitive behavioral therapy in the insomnia with short sleep duration. And this was published in 2020, 2021 of the Journal of Clinical Sleep Medicine. And here I would like to show you the results. Pre-treatment, post-treatment, 3 months, and follow-up 9 months. And you can see here with trazodone, we have a significant increase of about an hour of the sleep duration of the insomniac, while those on CBT, there was no difference. Therefore, trazodone appears to increase significantly the duration of those insomnia that sleep short. Furthermore, here we can see that trazodone, in contrast to cognitive behavioral therapy, had a significant lowering effect in cortisol levels, particularly in the evening hours, both at 3 months as well as at 9 months. At the same time, there was a paper in 2020 that came, and byproduct of this paper is we did a power analysis of the EEG, and we found that trazodone, but not CBDI, had a favorable effect on high-frequency activity during non-REM sleep in chronic insomnia, in contrast to CBT. In other words, there was a lowering of high-frequency activity and an improvement, a strengthening of the slow-frequency activity using FFT analysis. At the same time, another study published in the Journal of Alzheimer's Disease and came from UCLA. One of the authors is a Greek neurologist, Eliseos Karageorgiou, and it was a retrospective study, and they found that long-term use of trazodone was delaying the decline of patients that they were using this medication, and they had a diagnosis of cognitive impairment. Now, as I said, we are not married to trazodone, we are not tied to trazodone. Other medications, again, however, antidepressants, small dose. Here I show the results from a study in 2003 by a German group, Dr. Rodenbeck. Doxepin, again, is a medication that is used, it was introduced for depression, but it has a lot of side effects because it's in the group of tricyclics, a lot of anticholinergic, cardiac effects, dry mouth, blurred vision, and so forth. So it's not used, but in small dosages, 10, 25 milligrams, and now in the United States, even in 3 milligrams, 6 milligrams, has a very good effect on improving sleep, in lengthening the duration of sleep, and here it shows also it decreased the cortisol levels. So we would like to believe that this type of medications, that they tend to increase the duration of sleep, they tend also to decrease cortisol levels, they may be very useful in not curing, but delaying the progress of patients with mild cognitive impairment. Here is some data published in JAMA where it shows that contrary, to that trazodone is not FDA approved, that trazodone is not supported by industry. And in fact, the American Academy of Sleep Medicine has suggested to the doctors, don't use it because it's not approved and we do not know. The number of prescriptions has increased over the years dramatically. And I can tell you that in 2020, there were about 25 million prescriptions in the United States in a month in a small dose for trazodone. So you see here the discrepancy of what is in the books of what's in academia and what the average physician is doing, at least in the United States. Now, we believe the future directions is, first of all, because polysomnography, is expensive, it's cumbersome. In the United States, it's more than 1,000 to monitor someone in the sleep lab. We have to find more valid and ecologically friendly devices, such as actigraphy, but we're still there struggling with validity and reliability. So the current recommendation is to use actigraphy for 2 weeks. And also, we need large randomized placebo-controlled prospective studies examine differential treatment response of the two insomnia phenotypes. The outcomes can be hypertension, can be diabetes, can be cognitive impairment. Well, I think I made it in, so I allow time for questions. And here is a picture from the Penn State group. It was, I think, a Christmas picture. That's why you don't see Maria Basta, but you can see her name there, and several Greek names and from other nationalities that they have come and studied the sleep in Hershey, Pennsylvania. Thank you for your attention, and I'm open to questions and discussion.
Thank you, Dr. Vgontzas, for the wonderful presentation. And I really find this work very exciting because I think combining basic science with clinical practice is very, very significant for us being doctors. So now it's open for questions.
Can I go?
Oh, sure, Costa, go ahead.
Hi, wonderful talk, Aleko. It's great work and a great body of work. Taking things from our perspective, my perspective, which is more of the cognitive side, and I could talk to you about this all afternoon. I wanted to sort of bring up 3 possible topics for discussion. One is the mechanism question, the issue of what happens to brain protein clearance in the context of slow wave sleep, and whether that in some way reflects the association between that type of insomnia and cognitive decline. The second is I wanted to make you aware that actually my colleagues, Barry Greenberg and Paul Rosenberg, are leading a very large trazodone study focused on MCI people with impaired slow wave sleep, the goal being to see how trazodone impacts on slow wave sleep as a target engagement, first of all, but then secondarily, if that target engagement happens, what happens to cognitive change in people with MCI. So there are, and Christine Yaffe, who's at UCSF, not UCLA, and her team, they are doing a similar trial as well, but they're not in the field quite yet. So this is going to start happening. So the third point that you didn't touch upon and has lots of implications has to do with this peculiar phenomenon that affects about 40 or 50% of patients with dementia and smaller fractions of people with MCI. And that's the phenomenon of agitation that is increasingly linked to circadian rhythm disruption. And so I'm wondering if you have any comments about that. So Paul Rosenberg has a study where he's looking very closely at the relationship between actigraphy measured circadian and sleep measures and the emergence at different times of day of specific kinds of agitated behaviors. One of the thoughts that came to me as you were talking is, could this be mediated through cortisol, and how would that work, and how would you look into it further? So I don't want to hog all your time, so just to answer one of those, but I just thought it's a really neat talk, good opportunity.
All of these are wonderful issues that you raised, and I'm glad to hear, that some other people are working on the issue of trazodone and mild cognitive impairment and possible mechanisms. So I did not know that, and thank you very much for this information. Because, this study with trazodone we have started years ago. It took us some time. Now, as far as the circadian issue, Costa, I don't think we have studied. I can speak as a clinician, but not based on research. We are studying now the circadian effect in adolescents, where, as you know, there is a very strong effect. And we're finding that besides, the sleep duration, particularly in adolescents, circadian issues are very important in predicting cardiometabolic disorders and so forth. So I will not be surprised, because circadian also rhythms change as we get older, even in normal people, but more so in patients with this kind of problems, if circadian issues is another factor. But I have to say, we have not studied, and I cannot offer an opinion on that. As far as slow wave sleep, this is an area, that sleep physicians and sleep investigators, sleep researchers have been trying to understand for many years. And unfortunately, I have to say, they have not been able to find, when sleep is scored visually, the slow wave, the deep sleep, consistent difference between insomniacs and controls. However, when we do a power analysis, either using FFT, the fast Fourier transformation analysis, or the periodic tablet analysis, then there we can find differences between insomnias and controls. So my answer to that is, because we have spent also a lot of time on that, that visually scored slow wave sleep, it's not going to give us something meaningful. But using these mathematical ways, and even more sophisticated now ways to assess the power in slow wave activity, may be very meaningful. Just you remind me, that my first paper with George Chroussos was back in 1996. There was back then a so-called delta sleep-inducing peptide. And there was a Japanese group that published a book, and everyone thought that this would be an answer to the insomnia problems. But our study and other studies showed that that was not the case. So this research path was forgotten, didn't take us anywhere. So this question remains. I show you the data that we found in the difference between cognitive behavioral therapy and trazodone. I'll show you the data by Lyceos, where they're talking, that trazodone maybe is possibly a slow wave enhancer in this true mechanism. I do not know that. To me, the more something that I can grasp is through its effect on cortisol. And thank you for all your three issues you brought up. And by the way, Yannis had raised his hand, but as a follow-up statement to what Kostas Liketsos said, is that the competitor, the zolpidem, that used as a hypnotic in the United States, and I'm sure all over Europe, does not have the effect on cortisol that we were able to identify with, as I said, trazodone, or the German group with doxepin and so forth. And there is a new medication that has to do, with the orexin agonist, that it was just came out in the United States. I think I'm forgetting now its name, but it has to do with orexin agonist. And they said that it increases the duration, but I asked them, and they don't have data in terms of the effect on cortisol. Thank you. Yanni, I see you. Maria, you can give the
I'm sorry, I can't see everybody because my screen is very small.
Oh, I think I can see that Yannis Zaganas is raising his hand.
My virtual hand.
Your
So
virtual hand.
Thank you for the excellent presentation and for all the work all these years on these subjects. I was very impressed by the slide about the societies arguing against use of trazodone, and everybody, including me, using trazodone. So Because there are some, let's say, possible side effects of trazodone, how can we guard ourselves against, for example, legal actions or things like that? Are there any repercussions of this kind, like having guidelines and professional societies arguing against the use of trazodone? And on the other hand, we're seeing, and I agree completely, that it's a very useful drug.
I can spend, dear Yanni, I can spend half an hour, give you all the history of trazodone. Even in 2005, I'll tell you that, there was an NIMH symposium on insomnia. They have not invited us back then. And one of their conclusions is, don't use trazodone, 2005, okay? And I wrote an editorial, and I said, but well, it's been used. We're talking about 17 years ago. Let's study it. You know, there is no good study. And now, me and other colleagues, we have applied to NIH for a large study, and we still have a lot of resistance. There are some people that they love the study, so we're now appealing at a very high level of the Council of NIH. Interestingly, is that this drug, there are two things. It's not FDA approved. It is not also supported by any company. Okay, so remember all that. So there are no big studies. I just showed you a pilot study. There are very, very few studies. Now, in terms of side effects, Yanni, the answer is the following. For a medication that has been prescribed consistently for more than 20 years, and the number of prescriptions is going up and up, the average physician, as you know, wants his patient to be happy. First of all, to be effective, not to have a side effects. If it was not effective, why to use for 20 years? Why to have 25 million prescriptions in 2020? And this number goes up. And if we have a lot of side effects, you know, physicians, particularly in the United States, are very keen to this problem, and they don't want, you know, malpractice cases. And this is the only drug that no one, as far as I know, has sued a physician for prescribing a non-FDA approved drug with for an indication non-approved by FDA. So that's really the answer. The answer is the history of the 20 years, the tens of thousands of physicians that they prescribe it, and the millions of people that are using it. And personally, because I have been prescribing that medication for more than 20 years, yes, are there side effects? Of course there is side effects, particularly in older people, and that's something that I would like to bring to your attention. It may cause a little bit of orthostatic hypotension, particularly in women. So particularly in the first few days of using this drug, we have to be keen to this side effect. Occasionally, I have had people that have had nightmares, but the most frequent side effect, particularly in older people, and since all of you and all of us are treating also elderly patients, be careful about the side effect. No other major side effects. Now, does everyone respond to that? No, because as I told you, those with insomnia of normal sleep duration, they respond much better to behavioral therapy. And in fact, think about that. It's just simple logic. If you have someone who complains of insomnia and sleeps 7 hours, why he needs a medication to lengthen his sleep? We're going to make him a hypersomniac. He's going to be fatigued the next day, sleepy. So this medication is good for those with short sleep and normal sleep duration. Already I gave you some preliminary data and the meta-analysis. They respond better to the behavioral treatment. So it is possible if someone does not respond that belong to this phenotype that I called insomnia, normal sleep duration phenotype. And again, I want to emphasize to those not familiar with the sleep field that there is a big difference between objective measure of sleep and subjective. And in fact, the two things do not correlate. And this is another enigma that has, tortured the sleep field for many, many years, and there is no definite answer to that. While, let's say, for someone that sleeps 7 hours and says, I sleep only 2 hours. Yes, they say anxiety, memory, and this thing, but really grasp of this problem, I don't think we have.
Thank you, because I can sleep better tonight since I'm using trazodone in many patients. So
I would like to make a notice on that, since our audience is mainly Greek. Dr. Vgontzas is talking about the trazodone that used to be around in Greece, but it's not available anymore, not the CR form of the medication, which it does not, I mean, the pharmacodynamics are not the same, and it does not have the same sleeping effect as the plain form of the medication.
And the same price.
Yeah, thank you, Maria, for this clarification. And maybe for people outside of Greece, like Kostas Liketsos, when I came to Greece, the immediate release trazodone was available. But then when they introduced the slow release, they withdrew the immediate release. And now they're telling you, use trazodone 3 or 4 hours before sleep. But you can imagine, you know, that's not practical, and we do not know the mechanism, we don't know how it works. So we have here a problem right here. I mean, in Greece.
I have a question, but I think, Nico, you should go first because I've spoken.
No, actually, I don't have any questions. I'm on call, and I thought it would be very quiet, but it wasn't, unfortunately. So I just came in towards the end of Alex's presentation. So I missed it. So I don't have any comments. I'm sorry. Alec, I'm sorry.
That's okay, Nico. Okay.
So just a couple thoughts then, because I think an element of my last question that I'm going to nudge you back on, but societies, this sort of whole issue of society recommendation, it's easy for them to say what they're saying, but in the United States, access to CBTI for the average person with insomnia is almost zero. So if the alternative is a different pill, trazodone ends up being the safest, in my view, and I think Aleko, you know that you can
Sure.
argue with me on that, but I think it's close to the top. So societies tend to argue for an idealized world. I did not realize there was no immediate trazodone in Greece. That's too bad. The question is, what is the access to CBTI in Greece?
I think I can, other people can speak, but it's much less than in the United States. It's much less. If you think, Costa, that the United States is not accessible, in Greece, if you call it zero, then in Greece it's a sub-zero. And because here, you know, we still have the influence strong influence of the psychoanalytic schools, particularly the French school and so forth, that, by the way, I have to say that, and hopefully no one will get offended, but my professor, my mentor, Tony Kales, was a psychoanalyst, okay? Back in 1960s, you know, Costa, every psychiatrist in the United States was trained and personally analyzed. So it was Tony Kales and his wife. So when I started sleep medicine in late 1980s in Hershey, we always used to say insight-oriented psychotherapy. And I recall, you know, a couple of patients at the end, you know, because Kales had that big fame, you know, international fame for his sleep. And at the end, Kales will, you know, ask questions here and there, your childhood, mother, father, big, everything. And then at the end, he would recommend, you know, insight-oriented psychotherapy. And then I recall, you know, a lady, middle class, about 60, said, Dr. Kales, I know you're very famous. I came here all the way. She came from another state. But, you know, I have spent 15 years in psychoanalysis. My personality is better. My relation with my husband is better. My relationship with my friends is better. At work, I'm doing better. But this damn insomnia is insomnia. Can you do something better for me? And I remember I looked Tony Kales at the eyes, you know, sometimes these anecdotal histories are very important. So I'm saying that because if you think CBTI is not prevalent in the United States, is not easily accessible, then in Greece it's worse. Except if Maria disagrees, I do not know.
Unfortunately, I agree with you totally. There's not people who are trained to do it. And I think insomniacs may not be able to pay for it. So it's both issues, and they don't want to devote the time that it takes. So I think it's a big problem, and very, very few patients, insomnia patients, do get the right CBTI treatment, at least in Crete.
And unfortunately, I would say pharmacologically, Costa, it's that many physicians in Greece, they use, the benzos or BZRAs for insomnia. And as you know, they're not good, particularly for people with cognitive impairment. I have seen people using Xanax, using flunitrazepam, that in the United States, as you know, never was allowed in the market. When I came in Greece, I asked that flunitrazepam, which is the Blumelgalmar, how do we call it? Give me the trade name of this in Greek.
Hypnosedon.
Hypnosedon, yes, hypnosedon is one of the prescribed medications in Greece for sleep, although, it's highly abused in the streets. And the United States, it was never introduced. And when I came in Greece, I sent a letter to the corresponding FDA that said, please, for this and these reasons. But as you know, from the voice from a scientist to the politician, sometimes there is a lot of blocks and it doesn't arrive to the right place.
If I may intervene, another issue is that depression is underdiagnosed. So it may not be insomnia per se, but depression that doesn't get treated. And people, instead of getting antidepressants that will help with sleep later on, they get treated with all these benzos. I have to tell you that a couple of days ago, I saw an 82 years old from Sitia that came to the hospital because of insomnia. She was on 3 different benzodiazepines at the same time and no antidepressant treatment. And she was not feeling well, let's say. So what Dr. Vgontzas just described is a problem, indeed.
I imagine, Aleko, that Tony's daughter, Helen, is the director of psychiatry at UC Davis.
Yes, I do.
So, Helen's an old friend. She does what I do, although she's much more focused on behavioral management, but maybe she's someone we should bring into a future seminar.
Oh, yes.
This will be an area. I had hoped when I asked my question before that you might say something about what is happening in the brain during slow wave sleep, with the evidence now that during slow wave sleep, there is an expansion of the glymphatic system, which accelerates a clearance of waste products. And many people think that function during slow wave sleep is both connecting sleep disorder with cognitive decline, but also is the intermediate step between trauma to the brain and later cognitive decline. So chronic lymphatic impairment. So thoughts you have about that, because once we know how to measure that in the living person, it might be quite important.
To be honest, Costa, I did not know that. Thank you for this information. I will look into that. Thank you. I did not know that.
There has been a lot of the debate on that in the last European sleep research meeting on the glymphatic clearance and cognition. So it's a field that it's new, and I think there's a lot of research going on right now.
Yeah, there's very impressive murine data, animal data, linking changes in glymphatic flow to the equivalent of cognitive change in animals, and how that's influenced by trauma, by chronic sleep deprivation, and a variety of other paradigms. So that work is now coming into humans, but the challenge is measuring glymphatic flow in humans. There seem to be some MRI techniques that are coming online that will help in that regard.
Thank you, Costa. I guess there are no other questions. I think the time is about 6:10. What do you think, Maria? If there's
I can't see if there is anyone else that wants to ask something, but I guess we are done. I would like to thank everybody. Thank, first of all, Dr. Vgontzas for his wonderful talk, and all of you for attending this very interesting session. Have a nice evening, everybody. Bye-bye.
Bye.
Thank you.
Bye, everybody.
Thanks to all of you. Bye-bye.